Hello, everybody. Welcome to Remodeling Innovation, applying clinical research and real world experience with cardiac myosin inhibitor in hypertrophic cardiomyopathy and beyond. My name is Dr. Milind Desai from the Cleveland Clinic in Cleveland, Ohio, and it is my privilege to be joined today by Dr. Desai Owens from the University of Pennsylvania Perelman School of Medicine in Philadelphia, Pennsylvania. Thank you to PeerView and Mended Hearts for providing this session, and Bristol Myers Squibb for providing the educational grant that made this symposium possible. Throughout the presentation, please watch or follow up polling, and you can submit your questions using the chat features, and Dr. Owens and I will try our best to answer them live. You can view and download today's slides and helpful practice aids on the PeerView website. Additional helpful resources are available from Mended Hearts, who collaborated in the development of this activity. Mended Hearts is a very useful resource for both providers and patients. It is a not-for-profit organization that offers hope to patients with heart disease, their families, as well as care partners. There are multiple resources available for cardiomyopathy as well as for patients and care partners in terms of peer-to-peer support. There are multiple dedicated tools and resources. We would urge you to check out their website as well as the various aids that are available. What are our goals for today? We will explore the mechanism for cardiac myosin inhibitors and its impact on hypertrophic cardiomyopathy. We will identify ideal patients who are most likely to benefit from treatment with cardiac myosin inhibitors. We will discuss the concept of shared decision making to help integrate cardiac myosin inhibitors into treatment regimens for symptomatic obstructive HCM patients, including those who are candidates for septal reduction therapies, as well as evaluate the potential clinical implications of CMIs in non-obstructive HCM, as well as patients with heart failure and preserved ejection fraction. So I will kick things off by discussing what are some of the potential gaps in the diagnosis of HCM. Again, I'm Milind Desai from the Cleveland Clinic. So in terms of anatomy, as it relates to hypertrophic cardiomyopathy, the classic definition is you need an LV wall thickness of more than 15 millimeters or more than 13 millimeters in individuals who have a family history of HCM, or if it occurs in conjunction with a positive genetic test that is diagnostic for HCM. So the cartoon on the left is that of a normal heart, and the cartoons, the four cartoons from left to right, they represent various phenotypic appearances of hypertrophic cardiomyopathy. Often patients may present with a thick wall without obstruction. Some patients may have dynamic outflow tract obstruction of typically more than 30 millimeters of mercury. Many patients present with no LV outflow tract obstruction, but they have evidence of mid-cavitary obstruction. And there is a sizable group of patients who may present with apical variant hypertrophic cardiomyopathy. And it is important to note that progression can occur from one phenotype to the other. HCM is an equal opportunity offender, and it impacts all sexes, races, as well as ages in all parts of the world. It is certainly not rare with a prevalence of 1 in 500 based on imaging, but fairly clinically underdiagnosed. The median age is thought to be about 46 years, and this is an alarming number. There are 2 cases that are missed for every 1 case that is diagnosed. In the United States, there's thought to be around 700 to 1 million Americans who may have HCM. And clearly, there have been disparities demonstrated in terms of treatment as well as mortality that are based upon sex, race, insurance status, a location, rural versus non-rural, parts of the country, size of the hospital, as well as whether or not the hospital is a not-for-profit. When should I suspect hypertrophic cardiomyopathy? Unfortunately, the symptoms are similar to a lot of other cardiovascular diseases, but often are exertional dyspnea, dizziness, syncope, chest discomfort, which sounds like angina, palpitations, and symptoms may be dynamic and could vary from day to day. We have to be carefully and diligently looking out for family history, including autosomal dominant inheritance, unexpected deaths, sudden deaths, heart failure, stroke. And on physical examination, you could often have systolic murmur that is dynamic, changes with Valsalva, and maneuvers that increase preload. Often the initial presentation is abnormal ECG or arrhythmias. But it is absolutely important to know that HCM can very often be asymptomatic. What are some of the key imaging studies? According to the guidelines, transthoracic echocardiography is the primary modality for diagnosis and phenotyping of most patients. It helps measure wall thickness, characterize outflow tract obstruction, look at mitral valve, regurgitation, subvalvular apparatus. It is also used for screening and follow-up of these patients. CMR is a very useful adjunct in especially patients who do not have conclusive transthoracic echocardiography, but also for fibrosis assessment as well as precision in thickness measurements. In many patients, transesophageal echocardiography is used especially for planning for invasive therapies. With emergence and understanding that there are many phenocopies, especially things like amyloidosis, there's increasing role of nuclear perfusion scintigraphy to help decipher different phenocopies. So something to keep in mind. As we evolve into the world, the brave new world of artificial intelligence, there's emerging data that ECGs that can be studied using artificial intelligence and validated algorithms to make an earlier diagnosis or a more confident diagnosis of hypertrophic cardiomyopathy that may be missed on standard human eye assessment. And there are multiple companies that are working on developing these protocols and these products. One of them being Viz AI, which is one of the first companies to help approved by the FDA to help HCM detection. So before we move on, please take a moment to answer the follow-up polling questions on imaging studies in HCM. And I would like to introduce Roger, a man who is 58 years in age with obstructive HCM, with a history of persistent atrial fibrillation and hypertension. His father died suddenly at the age of 63, and he is currently in NYHA class 3 with maximum wall thickness of 22 millimeters, preserved ejection fraction, severe outflow tract obstruction at rest of 55 millimeters of mercury, and with Valsalva it increases to 85 millimeters. A murmur of mitral regurgitation is present, vitals are stable, patient is tachycardic, and he's on metoprolol 100 milligrams twice a day. Disopyramide was discontinued as Roger complained of significant side effects of dry mouth and urinary retention. He presents with worsening symptoms of dyspnea and fatigue, irregular palpitations and dizziness, and reports that his symptoms have progressively worsened. Before we move on, please take a moment again to answer a polling question for what you perceive are next steps for Roger. So now, with that as a backdrop, it is my pleasure and privilege to introduce Dr. Desai Owens, who will provide her research insights into the latest clinical trial results for cardiac myosin inhibitors. Dr. Owens.
Thank you, Dr. Desai. It's my pleasure to be here with you today. And as you know, it's been a dizzying pace of new data coming out of clinical trials for the cardiac myosin inhibitors. And I'll do my best to walk us through the latest data on CMIs. So let's start by considering what we had before the first in-class cardiac myosin inhibitor, mavacamten, was approved, which was in 2022. So before that era, for the decades prior, we were using medicines that were not developed specifically to treat hypertrophic cardiomyopathy, but rather were being repurposed from other indications. And these medications included beta blockers, non-dihydropyridine calcium channel blockers, and the antiarrhythmic medication disopyramide. So we were using these medicines on the basis of expert consensus and small, mostly single-centered, non-randomized studies. We know that these drugs were not developed to treat the underlying pathophysiology, and in many cases, we found that they did not provide sufficient symptom relief. Patients may feel partially better, but many of these medicines often come with side effects, particularly at the higher doses. And so what we found was undertreatment overall of many of our patients with symptoms from obstructive HCM. In 2022, with the indication of mavacamten being FDA approved for patients with symptomatic obstructive HCM, we found that more real-world use occurred, and the use of cardiac myosin inhibitors is now incorporated into the guideline recommended therapies, both in the European HCM guidelines in 2023 and more recently the AHA-ACC guidelines in 2024. So what are these small molecules and how do they work? So this is a new class of medications, cardiac myosin inhibitors. There are two medications that have completed phase 3 trials, one of which is currently FDA approved, that's mavacamten. Both of these medicines work by modulating contractility, and they are designed to work at the level of the sarcomere, which of course is the contractile unit of the heart, and they mitigate the hypercontractility that we see as part of the pathophysiology of HCM. And that's what makes these molecules potentially disease modifying for patients with hypertrophic cardiomyopathy. And as opposed to the other agents that we were using, the non-targeted therapies, these drugs have been rigorously studied in prospective randomized controlled trials. So to give you a sense of the history of the trials that we've seen, this is a summary of selected phase 3 clinical trials with the cardiac myosin inhibitors. And we started with the pivotal phase 3 trial, the Explorer trial of mavacamten versus placebo in patients with symptomatic obstructive HCM. This is the trial that led to the approval of MAVA for commercial use. Patients from the Explorer trial were able to roll into a long-term extension trial called MAVA-LTE. And you'll notice that there were also patients from the Maverick trial who were included in that open label study. And those patients from Maverick had non-obstructive HCM. That open label extension trial is ongoing. The second phase 3 was the Valor HCM study. This enrolled sicker patients, all of whom were eligible for septal reduction therapy. The vast majority, over 90%, were class 3, and that phase 3 trial has completed. And then we have one phase 3 that has been completed for aficamten, the next in class cardiac myosin inhibitor, and that's the pivotal trial Sequoia that was published earlier this year. So let's look at the latest data that's been published out of these trials. Let's start with MAVA-LTE. Again, this is the open label extension for patients who were enrolled in Explorer and have now continued on to MAVA-LTE. And this data is 3.5 years of efficacy and safety. And what we notice is, first of all, a sustained benefit on gradient reduction. That's pictured in the middle with resting LVOT gradients going from severe to normal in the aggregate population and sustained out to 180 weeks. And similarly, a profound drop in Valsalva gradient after starting therapy that is sustained out to 180 weeks. The other things that we looked at in terms of biomarkers, we saw a sustained improvement in NT-proBNP, an improvement in quality of life scores, and we did notice by mechanism of action an expected drop in LVEF. Now that went from about 74 at baseline to about 64% over the 180 weeks. That's an aggregate. And there were individuals who could have a drop in ejection fraction to less than 50%, but in aggregate, the LVEF remained within the normal limits. And notably, importantly for our patients with HCM, 78% improved by greater than or equal to 1 NYHA functional class. And in this disease, we are really looking for symptomatic improvement and functional capacity improvement, quality of life, and that's what we saw. When we look at safety of mavacamten, importantly, over 3 to 5 years, we want long-term data with this new class of medications. You'll see that the most common cardiac-related treatment emergent adverse events were hypertension, atrial fibrillation, dyspnea, palpitations. Ejection fraction being decreased occurred in approximately 5 to 6% of patients in the MAVA LTE study. And when you look at the exposure adjusted incidence over time, you can see that those incidence rates are decreasing. So again, that's reassuring that we're not seeing more side effects or adverse events. We're seeing fewer adverse events over time. When we look next at the latest VALOR data, I'll first show you the 56-week data and then the 128-week data. This is the 56-week data, looking at patients, again, who were sicker than EXPLORER. All were candidates for septal reduction therapy at baseline, and you'll see that represented by the green bar at 100%. And over 56 weeks of treatment, we again saw robust decrements in LVOT gradients to the level that many patients were no longer considered obstructive. And that placebo group, as soon as they crossed over to the mavacamten, caught up with their mavacamten colleagues, and everybody was sustained reduction in LVOT gradient. And we were looking at a primary endpoint of who remained eligible for septal reduction therapy. This was a novel endpoint. And as you can see in the purple and red bars, by week 32 and 56 of therapy, very few patients remained eligible because they improved their gradients and they improved their symptoms. Here's the 128-week data. Again, patients from the VALOR trial. And at week 128, 15.7% of patients met the composite endpoint. Again, that is eligibility for septal reduction therapy or the choice to actually undergo septal reduction therapy. And you can see there that 7 patients chose to undergo septal reduction therapy. I'll call your attention to the right side of the graph where we look at the quality of life by the KCCQ score, and then we look at biomarkers. And again, reflective of what we've seen in EXPLORER, in VALOR, and through the long-term extension, we see sustained improvements in quality of life scores and in biomarkers. So in summary, what we saw in the long-term extension data of VALOR is that mavacamten was able to reduce the need for patients who had highly symptomatic obstructive HCM that was maximally treated with medication. It reduced their need to undergo invasive septal reduction therapy. Additional changes that we saw from the VALOR trial, this gets into remodeling of the ventricle and echocardiographic improvement. We saw serial changes in ventricular strain in patients from the VALOR trial. And our main findings were that mavacamten improved LV global longitudinal strain from baseline to week 56. It was unchanged in terms of strain of the right ventricle. We want to make sure that we're not having adverse events on the right ventricle, and we did not see that. And even in the group who transiently dropped their ejection fraction to less than 50, that's on the bottom right, there was no worsening in their global longitudinal strain. This suggests to us that there may be a favorable long-term impact on regional LV function through the use of a cardiac myosin inhibitor. Looking at change in health status, again, for our patients, quality of life is very important in this disease. And we saw sustained improvements in patients out through week 56. The placebo group caught up with their counterparts once they started mavacamten, and you can see that there is a sizable proportion of patients who actually had quite a dramatic greater than or equal to 20-point increase in their KCCQ scores over time. And this shift was remarkable in our patients, and we found that 89% chose to continue the drug rather than undergo invasive septal reduction therapy. Here's data that is pooled safety data. This is the first presentation of this data in abstract form. It was from 5 trials looking at mavacamten. This was the phase 2 Pioneer study and its long-term extension, the phase 3 Explorer study and the long-term extension, and the Valor study. And here I'll call your attention to treatment emergent adverse events, which occurred in 20% of patients treated with mavacamten. Fortunately, only 4% were serious treatment emergent adverse events. And we had a special attention to AEs of clinical interest, which we defined as atrial fibrillation, ejection fraction decreased, or heart failure incidence. And these are really important to make sure that we're not seeing an increase in adverse events over time. And what you can see starting on the left side of the graph is year 1, all the way out to the right side, which is year 5. We are seeing a decrease in exposure-adjusted incidence rates. And that's important because natural history of HCM would suggest that patients get more heart failure symptoms, more AFib over their lifetimes. So the fact that we're seeing a decrease on mavacamten is an encouraging sign. Here is data from the pivotal phase 3 Sequoia HCM. This is the first phase 3 to be published for the next-in-class agent aficamten. This was 282 patients, all with symptomatic obstructive HCM. As you can see, they had baseline LVOT gradients that were in the severe range, hyperdynamic ejection fraction as expected. Now, the primary endpoint of this trial was peak VO2, and I have that pictured in the graph to the right, both the peak oxygen consumption on the left, aficamten versus placebo, and then the least squared mean difference, which was 1.7 mils per kg per minute, highly statistically significant and clinically significant change between the aficamten and placebo groups. Looking at aficamten's effect on cardiac structure and function, again, we like to look at symptoms and biomarkers, and between 50 and 60% of patients had an improvement by greater than or equal to 1 functional class. We see a very robust reduction in NT-proBNP that's pictured on the left side, with many patients normalizing their NT-proBNP. After the drug was stopped at 24 weeks during the washout period, those biomarkers returned to baseline. We saw the similar effect on gradient reduction, both at rest and with Valsalva, with aficamten pictured in red versus placebo in blue. We saw, by mechanism of action, a slight decline in ejection fraction, with the overall aggregate population remaining in the normal LVEF range. And we saw an improvement in left atrial volume index, again, suggesting that there is beneficial remodeling that's occurring on the basis of cardiac myosin inhibitor therapy, in this case, aficamten. This was an exercise sub-study that was done from the Sequoia population, and this included a novel integrated composite exercise performance score. It integrated not only peak VO2, but also a measure of submaximal exercise with the VE/VCO2 slope. And that was converted into a Z-score, and we found that the score improved in patients who were treated with aficamten versus placebo. There was a beneficial effect on a number of other exercise parameters that was shown in this sub-study. Here's health status outcomes, again, quality of life with aficamten versus placebo from the Sequoia trial. And one thing that's notable, and Dr. Desai and I have seen this and discussed it, there's quite a placebo effect in these trials in patients with HCM. So it's something certainly to consider as we design these trials and as we look at the results, that there is a significant placebo effect. But what I think you'll see is that when you get to the very large improvement on the right side of the screen, it's pretty clear that the cardiac myosin inhibitor aficamten was having a large effect on patients who had really profound improvement in health status. This included both an angina score, the Seattle Angina Questionnaire, and also the KCCQ score. Looking at safety in aficamten, there were not a lot of serious adverse events, thankfully, and they were pretty equal between placebo and aficamten treated patients. In terms of side effects that were common adverse events, we saw more hypertension and more palpitations versus placebo in the aficamten treated group. There were 5 patients, which was about 3 to 4%, who had a transient drop in LVEF to less than 50% in Sequoia. Because aficamten has a shorter half-life, they did not interrupt treatment, but they down titrated the dose, and none had an exacerbation of heart failure in this study. Before we move on to the next section, please take a moment to answer a follow-up poll on medication classes for HCM.
That was great. And now, as all of us have heard, the the mavacamten has been approved by the FDA and is commercially available in United States as well as multiple countries around the world. So now we have started to accumulate real world evidence and experience with managing patients on mavacamten. So let's briefly talk about that. So, because of the high quality research trial data, the guidelines, the American Heart Association and ACC quickly realized that and have made significant recommendations. Now, essentially, if you have a symptomatic patient with obstructive HCM, your first line therapy is beta blocker, verapamil, or diltiazem. And if you remain symptomatic, then it's a class 1 indication according to American guidelines to initiate patients on myosin inhibitor, in this case mavacamten, as it is commercially available right now. The guidelines still resort to giving a class 1 indication to disopyramide, and in many cases, if patients choose to go straight to septal reduction therapy, it also gets a class 1 indication. But we now have novel therapies as getting a class 1 indication according to the most recent guidelines. It is important to recognize, and the guidelines recognize this, that patients with HCM, for that matter, every patient, shared decision making is crucial nowadays. In the case of HCM patients, shared decision making is often utilized, whether to do genetic testing, family screening or not, ICD implantation, what type of therapies you're going to use to relieve outflow tract obstruction, as well as an important discussion about physical activity as well as participation in competitive sports. Clearly, these decision-making conversations should include full disclosures of risk benefits as well as outcomes of all options, and also understand and give opportunity from the patient and the family members' perspective to understand, recognize what they want in terms of their disease and their life, and basically recognize that everything may or may not be available at your center, and often you may need to refer the patients to high volume centers of excellence. So let me talk about this real world experience at the Truman Medical Center. And the question here is, why do few eligible patients receive mavacamten therapy? Basically, we are talking about 115 patients, of which almost 43% patients met criteria for mavacamten therapy. However, only one patient out of 115 was taking mavacamten. Based upon some analysis, they recognized that some of the obstacles included lack of insurance coverage, high medication costs, and limited awareness amongst clinicians for new treatment options. 84% patients had preserved EF, 66% patients had clinical heart failure diagnosis, 82% had Verum beta blockers, and pretty much everybody had a elevated, about 43% patients had an elevated blood pressure. So this is something important for us to have an introspective look about why this, what are the barriers. So one of the barriers, potential barriers, is that mavacamten was approved by the FDA under the Risk Evaluation and Mitigation Strategy, REMS program, because of the recognition that reduced ejection fraction may occur. Hence, you need monitoring of LV ejection fraction. Do not initiate if it is less than 55% and interrupt if it is less than 50%. There's the possibility, because of interaction with the cytochrome P450 system and its excretion, there is a possibility that drug-drug interactions could occur, which may increase the risk of heart failure. As a result of that, it is important to check medication lists as well as drug-drug interaction. And all of us, providers, pharmacy, patients, need to be on the same page, which the REMS program ensures or necessitates that all the stakeholders, including the patients, undergo requisite training before they initiate mavacamten. So recently at the American Heart Association 2024 meeting, we presented the real world experience from mavacamten from the first 22 months. There were more than 6,000 patients with symptomatic obstructive HCM patient. Every patient in the United States who was enrolled in the REMS program in the first 22 months was part of this report. Amongst patients, basically what we found was 5,573 patients got at least one dispense of mavacamten. 29,000 patients had submitted patient status forms. And what we found was EF less than 50% was observed in 4.6, between 4 and 5% patients. Less than 1% of this patients submitted forms. Heart failure hospitalization was seen in 1.3% patients, and a combination of EF drop and heart failure hospitalization was seen in well under 1% patients. Out of the 52,000 drug interaction checklists completed, there were 0.25% which resulted in mavacamten dose reduction, and less than a third of 1% resulted in discontinuation of a concurrent medication. So the experience so far has been favorable, and there were no additional real life safety signals noted. Out of the 3,228 patients who got treated with mavacamten for 6 months, at baseline, 100% patients had a gradient in the severe range of more than 30 millimeters of mercury. And at 6 months, basically 70%, so more than two-thirds, had a very favorable response of gradients that were less than 30 millimeters of mercury. In fact, 56% patients had gradients less than 20 millimeters of mercury. So treatments, patients, basically, again, this is reiterating what happens in longer term treatment. So folks who got treated for more than 1 year, the EF drop less than 50% was again 4%, which is similar to the shorter or the overall real world experience. Same way, heart failure hospitalization was 1.5%, and the combination was about 0.2%, well under 1%. So clearly, as part of the REMS program, the way it is currently set up, it requires ongoing echocardiography to monitor structure and function of the heart prior to initiating therapy, 4 weeks, 8 weeks, and 12 weeks after initiating therapy. And then if you change the dose, adjust the dose, then 4 weeks after every dose increase. But once you reach steady state, 3 monthly, till for as long as you are on mavacamten. This may change in the future, but this is how the REMS program is set up currently. Mavacamten, as has been shown in clinical trials, is associated with substantial health benefits, including improvement in symptoms and quality of life. However, the pros and cons of imaging, frequent imaging, should be discussed with patients before initiating therapy. Drug-drug interactions, this is important, but as we have shown just in the few slides prior, the proportion, if done well, this is a very small proportion of patients have problems. So mavacamten is contraindicated in some cytochrome P450 inhibitors and inducers, especially moderate to strong inducers or inhibitors. What are some of the examples? So the parts of Paxlovid, which is a COVID drug, is contraindicated. Omeprazole is a prominent DDI, and we recommend switching to pantoprazole, cimetidine, fluconazole, and other antifungals. And a dose adjustment may be needed if you are using amiodarone. There is some clinical experience that suggests that there could be probable interactions with excessive alcohol intake as well as marijuana. So it is prudent and important to get a thorough social history. Bottom line is multidisciplinary collaboration, including patients, physicians, nurse practitioners, pharmacy, is important and has been successfully used to ensure safe use of mavacamten. I'll present some data, and there's a lot of newer data from multiple centers emerging. This is our data from the Cleveland Clinic in the first 150 consecutive adults who were treated with mavacamten. Mean age was 65 years, and 83% were on beta blocker, and 61% were NYHA class 3 at entry. Vast majority of the patients were on the lowest 3 doses. Only 2% patients received 15 milligrams of mavacamten. And at 12 weeks, the real world outcomes were very similar to the trial results as it relates to functional improvement, LVOT gradient, as well as need for septal reduction therapy. In fact, how many in a real world HCM population, how many may be eligible? One center found that 20% patients would have met criteria for either mavacamten trial, with more than 50% being potential candidates for Explore-HCM. So these patients are out there. The data, again, as I alluded to, as part of our real world experience, the EF did not significantly worsen. The resting and Valsalva gradients improved similar to the trial data, and 46% patients as early as 12 weeks had at least 1.1 class NYHA improvement. 1 in 5 had a 2-class improvement, and about 27% reported no change in symptoms. Even in the folks who had no change in symptoms, they had similar reduction in resting and Valsalva LVOT gradient, suggesting potential other etiologies like diastolic dysfunction as the cause of their symptoms. And similar to the real world REMS data, only 2% patients required temporary interruptions. And as of the last evaluation, no patient needed septal reduction therapy or had LVEF drop less than 30%, or heart failure requiring readmission. So perhaps maybe the world may be moving towards less frequent monitoring. And another important thing to mention, a lot of patients, 1 in 5 patients, we were able to eliminate or reduce background HCM therapy, which potentially helps reduce adverse effect of beta blockers as well as disopyramide. Additional data, again, from my friend and colleague, Dr. Owens' group at University of Pennsylvania, in 96 patients, again, symptomatic HCM, 63 years, 54% female, initiated mavacamten. By week 36, more than 90% attained complete hemodynamic response, and the median time was about 4 weeks to do so. Similar to previously published data, only 2 patients had temporary interruptions in less than 50%, no deaths, MACE, or hospitalization. And again, similar, the graphs show a very similar story to the real world data as well as the trial data in terms of NYHA class improvement, mavacamten dose usage, as well as LVOT gradient. Important to know, all these trials, as well as all these real world data, are showing that the maximum efficacy can be achieved by using the lowest lowest two or three doses. So we don't need to go on the highest dose, which potentially can increase the risk of ejection fraction drops.
So Malin, say you just met this patient in clinic. What further, tests would you be ordering? Comprehensive evaluation of HCM would you do at this point?
That's important. First and foremost, after confirming the detailed history, I am a stickler for looking at the actual images. So I am definitely going to look at the echo myself, but also we would discuss getting additional testing, additional phenotyping. Most common test I would do is a cardiac MRI to confirm the wall thickness, etc., but also to look for myocardial fibrosis or late gadolinium enhancement. We would, often patients present with anginal symptoms, and the patient is certainly in the similar age demographic. Then I have to make a judgment call: do I need to assess coronary artery disease concomitantly or not? But the other thing we would be talking about is genetic testing and genetic counseling. Screen how many children or first degree relatives this patient has, and recommending counseling for counseling as well as testing of the first degree relatives. And of course, after all these things, another important thing is a Holter monitor, or make a decision about longer term arrhythmia monitoring if it is needed. And then clearly we need to talk about, once all these imaging things are done, Anjali, where do you think you would go in terms of discussion of further management?
Yeah, it's a great point. I mean, we clearly have somebody who's class 3, is quite symptomatic with severe obstruction at rest. I think one thing that we haven't yet touched on, which I think plays a major role, is the presence of AFib. And here we have, by history, that it's persistent, but then we have a little bit of a discrepancy when we see the echo with only mild left atrial enlargement. And as you highlighted, there's nothing that replaces really seeing those images yourself, because we would be unlikely to, expect only mild left atrial enlargement with persistent AFib and severe obstruction. So if the left atrium is truly only mildly enlarged and the AFib is not persistent or permanent, we try pretty hard to get people back into sinus rhythm in conjunction with treating their severe obstruction, in the hopes of getting their heart as compensated as possible and to get them to feel the best that they can. He has just come off of disopyramide because of pretty common side effects that we see with that drug. So I think we'd be thinking of a strategy in parallel to either do septal reduction therapy, myectomy plus MAZE, or using a cardiac myosin inhibitor, potentially in conjunction with an antiarrhythmic if the AFib is paroxysmal and potentially there's a chance to get him back into sinus rhythm. I'm curious to see what your approach would be.
And I think you are spot on about, that's how I would think about it. I am a big stickler for, especially with the business of AFib, I'm a big, big stickler of having discussions about avoiding alcohol. Certainly, I start with saying avoid excessive alcohol, but then I am now pushing more and more towards avoiding any alcohol. And again, the shared decision making, like you said, are you willing to go? Do you want to go straight for septal reduction therapy when we can approach? Do we consider doing a MACE procedure, or do you want to try medical therapy first, antiarrhythmic? Or again, the other thing I'm also getting more and more aggressive about is referral for AFib ablation, especially with these newer the PFA type techniques. So do you want to go electrophysiology plus cardiac myosin inhibitor route, or do you want to go septal reduction therapy route? Either way, you, the patient, you, Roger, needs to be mindful of how much alcohol you take. Make sure you get yourself tested for sleep apnea if you are overweight, etc.
Yeah, such a huge point. The comorbidities that we see in our patients are, really rampant: hypertension, obesity, alcohol use, sleep apnea, etc. I agree that's a great approach. The other thing I think is important when we're starting myosin inhibitors is to try to maintain sinus rhythm. We know from the clinical trial data and from real world data that that is a time when you go into rapid AFib where you're prone to drop your ejection fraction even without a cardiac myosin inhibitor. And so with the addition of a CMI, I think you do need to be careful about rhythm control.
And the AFib, just natural history of HCM has a fair bit of AFib, and you want to get ahead of it. And to me, the longer you wait in terms of AFib, uh, the less likely you are going to maintain sinus rhythm on them. So these days, I've gotten a lot more aggressive at getting an electrophysiology opinion about the optimal timing for ablation, etc. And to me, more and more, I find myself having that conversation just as vigorously as I'm having conversation about treatment of symptoms of obstructive HCM.
Totally agree. We should do both in parallel.
So let me ask you a question. So let's say this gentleman says he wants to try medications first, and if that doesn't work, he's not averse to septal reduction therapy, but he wants to try medical therapy first. How do you approach it in your practice?
So our typical approach in a patient who's in AFib and very symptomatic is we would have that electrophysiology consultation, potentially admit the patient to start an antiarrhythmic plus a cardioversion, plus or minus ablation, depending on how much had been tried before this attempt. But if he had never had an attempt at cardioversion and antiarrhythmic therapy, we would do that. And in parallel, we would then start the process of getting approval for mavacamten and start the MAVA. And we would do those in parallel with close follow up and see how his response is. If he doesn't have the right response or doesn't feel well enough, or we can't get the gradient down and he wishes to then pivot to septal reduction therapy, we would stop mavacamten, have a washout period prior to doing septal reduction therapy, either with a myectomy or alcohol ablation.
How much do you recommend in terms of the washout period?
We typically do the same protocol that we did in Valor. As you know, we wait, about a month or so, 4 to 6 weeks, to ensure that the drug has washed out. I think anytime you're doing cardiac surgery, cardiopulmonary bypass, it's important that the CMI has washed out of the system.
Absolutely. Cannot underscore the importance of that. And the other thing also, as we navigate this process of cardiac myosin inhibitors, etc., it is important that the patient recognizes that this is not a one size fits all and just, either this way or that way. You have options. We are going to have frequent touch points. The other important thing, and I've learned it starting Hampton in a lot of these patients, is pay diligent attention to the findings, because not everything with thick walls is HCM. I've experienced patients, as so have you, where patients has a flail mitral leaflet or a subaortic membrane or amyloidosis or something else. You got to be very diligent in how you diagnose, or be confident in your diagnosis. You do not want to initiate wrong therapy for the wrongly diagnosed patients. So that's why I strongly urge everybody to don't just look at the report, but look at the images yourself.
Absolutely. And the additive benefit of getting that tissue characterization on MRI, or if you're at all suspicious, getting, a pyrophosphate scan to rule out amyloid is really worth your while in the beginning. Particularly now that we're in an area of targeted therapies for multiple cardiomyopathies. We have enzyme replacement for Fabry, we have multiple therapies for amyloid. It's really critical that we don't stop at the diagnosis of LVH and that we really characterize the reason and the etiology of the cardiomyopathy.
And Anjali, let me ask you a question while we are at it. So the septal reduction therapy, it's A, not a one size fits all, and B, it's the outcomes are not homogeneous across centers, across regions. How do you discuss that with your patients? And what is are all SRT procedures the same? And what is the value of a badly done SRT, etc.? How do you navigate that?
So, here we use a heart team approach, similar to how we approach other structural interventions, like aortic stenosis, for example. So, we have a team consisting of our surgeons, our interventional cardiologists, our imagers, our HCM docs, and we have a monthly call where we discuss all of the cases who could be eligible for septal reduction therapy. So, we have the medical multidisciplinary team discussion. And then we have that very important shared decision-making discussion with the patient and with their family. Once we see which options we think they would benefit from the most, we present those options and see where their preferences lie. And I agree with you. You don't want a poorly done septal reduction therapy. You end up with more problems, potentially complications, no improvement in symptoms, and you're sort of behind the eight ball. So we do try to avoid that. Unfortunately, as you know, if a procedure is done at a lower volume center, we're less likely to get a favorable outcome. So it's really important to partner with our community partners to say, send the patients in for an evaluation if you are thinking that septal reduction therapy may be in their future, so that we can help to make that decision.
I mean, I completely agree. And, look, I am blessed to be working at a high volume center, surgical center. So but still, it is absolutely important to have that shared decision making conversation with the patient, because not everybody wants to jump straight into surgery. At the same time, there are patients who are evaluating options. Do I stay on a medication for the longer term, or shall I deal with a septal reduction therapy procedure one time? So these are nuanced conversations. But again, the bigger nuance I find myself is that anatomy suitable for an appropriate response to drug, or is that anatomy more feasible to an alcohol septal ablation approach versus a surgical myectomy approach? So all these things have to, and this is where importance of a team approach, a heart team approach, and experience at high volume centers is absolutely crucial. So please answer this question before we move on what the next steps should be for Roger. So I turn over to Dr. Owens, who will discuss insights from the Mended Hearts webinar.
Thank you, Dr. Desai. Great real world data that you presented there. And next, we're going to look to the future. We're going to talk about trials that are ongoing, up and coming, both cardiac myosin inhibitors and beyond, and the frontier that we all hope to conquer, which is the symptomatic non-obstructive HCM patient, poses a major challenge currently with no targeted therapies. And we had a chance to speak with the patient during this Mended Hearts webinar about her journey with HCM. And really, it was a lifetime journey, as you can see here by her timeline, that spanned over decades of various complications that we see with HCM, treatments that were tried, runs with atrial fibrillation. Unfortunately, she had a TIA during that time. She eventually needed a prophylactic defibrillator. She, after alcohol ablation, became non-obstructive. But as we know, you can still have significant symptoms and diastolic dysfunction and heart failure symptoms, even after complete resolution of your obstruction, if you remain with elevated filling pressures and a stiff heart. And that's what happened to this patient. And ultimately, she decided to enroll in the Odyssey trial for symptomatic non-obstructive HCM. And we caught her right at the time that she was transitioning from the randomized placebo-controlled portion to the open label portion. And she was able to share with us that her symptoms had improved since starting the medication. So what is the future going to look like in terms of trials that are coming and the non-obstructive HCM landscape? So here are ongoing trials. I'll call to your attention two phase 3 trials, Odyssey HCM, which has completed enrollment. We are expecting results ideally, hopefully, in the next year. This was mavacamten versus placebo for symptomatic non-obstructive HCM. We have a similar phase 3 trial, Acacia HCM, for symptomatic non-obstructive HCM, looking at aficamten versus placebo. This trial continues to enroll actively at this point. We have Forest HCM, that is a phase 3 open label extension for patients with all kinds of HCM. One subgroup will be the non-obstructive group. That's the Forest HCM study, looking at aficamten. And then at the bottom, I have two studies, one a phase 2 that was completed, Improve HCM, looking at a novel agent that targets energetics. We'll talk a little bit more about that, niraparib, and a phase 3 trial, including both patients with non-obstructive and obstructive HCM, looking at SGLT inhibition. This is sotagliflozin versus placebo. So again, we've got a lot of excitement and a lot of trials that are underway. I'll summarize for you what we've seen in the non-obstructive HCM cohort so far with regard to response to cardiac myosin inhibition. So here I've shown the Maverick phase 2 dose-finding study of mavacamten, the Redwood phase 2 open-label non-obstructive study of aficamten, and the Forest long-term extension. And what you can see and what the signal has been so far is a reduction in cardiac biomarkers, in particular looking at NT-proBNP, and the reductions are highlighted here. This again is a mechanistic signal to us that hopefully there are improvements that we're seeing in the heart and will perhaps lead to remodeling changes that are favorable, symptom improvement that's favorable, yet to be seen in the phase 3 randomized studies. This is niraparib, a novel cardiac mitotrope. So this drug shifts cardiac energy metabolism from fatty acid to glucose oxidation. So this is a different mechanism. This is not myosin inhibition. And I think ultimately with HCM, as we've seen in other diseases, we need to target all the potential mechanistic pathways in order to develop what really is guideline directed and hopefully disease modifying therapy for this disease. And we're in the early stages of understanding how shifting energy metabolism might help HCM. This was a phase 2 study that was completed. What it showed is that niraparib was safe and well tolerated. There were hints of perhaps improvement in exercise performance that was evaluated by ventilatory inefficiency or efficiency in this study, and potentially a signal for improvement in health status in those patients who were the most symptomatic at baseline. So on the basis of these results, we are expecting a phase 3 study of this drug in HCM. And here is the results of the Embark HFpEF study. So this is taking cardiac myosin inhibitor mavacamten, but moving it outside of the HCM population and into a group of patients with HFpEF. So this was an open label design exploratory study, single arm, multi-center, and I'll call your attention to the doses of mavacamten that were used in this exploratory kind of proof of concept study. 2.5 milligrams and 5 milligrams. The higher doses of cardiac myosin inhibitor were not used in this study. And the primary endpoints were really to look at 26 weeks, whether there was a change in biomarkers. and to show whether or not this drug would be safe in a HFpEF population. And what we saw was improvement in biomarkers and a mild decrease in ejection fraction in the range of 3%. There were 3 patients in this study who had a transient drop in LVEF to less than 50%. We know this drug is reversible, so by temporarily stopping the drug, the ejection fractions recovered in those patients. So again, proof of concept phase 2 study.
So I think this has been a tour de force, hopefully, in terms of summarizing where we stand right now. What are the rabbit holes we need to be ready for in terms of imaging and diagnosis? What's the clinical trial data? What's the real world experience? And what's coming down the pike? So what are some of the key takeaways? Again, make no mistake about it, HCM is an equal opportunity offender, and we have to be on the lookout, as many of these patients can be completely asymptomatic. Multimodality imaging is recommended to diagnose, and phenotype as well as stage HCM. A lot of excitement with the development of cardiac myosin inhibitors, which are the first targeted therapies for obstructive HCM. First in class mavacamten, which is not commercially available, and we through a REMS program, but we are now talking about thousands of patients on this therapy and with good safety profile. Next in class aficamten has completed its phase 3 trials, and with the passing of years, we will see what I expect is similar long-term safety as well as efficacy data. Again, cannot underscore the importance of us accumulating real-world experience, which so far has been very positive in terms of efficacy, safety, tolerability. I would venture out to say it has been comparable or even superior to what we have seen in clinical trials. And as Dr. Owens presented, stay tuned for what's coming down the pike in terms of clinical trial results and potentially expanding the role of these therapies into other phenotypes of non-obstructive HCM as well as HFpEF and newer therapies that are in the horizon. So before we move on, please take a moment again to answer 3 questions about your practice strategies. Again, on behalf of Dr. Owens, thank you so much for joining us today. Please do not forget to complete and submit your post-test and evaluation for credit, and to download the slides and practice aids. And also watch for the online version of this activity in the coming weeks. Again, on behalf of Dr. Owens and myself, I sincerely thank you for your participation.